So we're a little bit ahead of schedule, but we'll probably use the time wisely. So yesterday I talked to you about Hypertension 101, and I gave you an update on the guideline on hypertension. And I know that was a lot for you all to take in such a short amount of time, but hopefully you'll be able to go over those slides and look at them in a little more detail. Now this talk I consider Hypertension 202, and it's great for primary care specialists because it gives us an opportunity to understand some of the challenges in patients that come to us often on 3 or more medications and remain uncontrolled. We are going to have a new guideline on resistant hypertension sometime after February of this year. It will be published like the 2017 updated guideline in overall hypertension in the journal Hypertension. But it's not out yet. But in the 2017 ACC-AHA update, there are some hints in that document, all 190 pages of it, that suggest how they're going to approach a little bit resistant hypertension. So I've culled some of that, put it all together, and I hope this will be helpful for you to look at the patients with resistant hypertension in your practice. Of course, the guidelines suggest, and I'll show you, the recommendation for referral to a hypertension specialist, but many primary care clinicians are hypertension specialists, and I always feel the more we know, always refer when you're in doubt, but the more we know, the better for the patient because it's easier for the patient, their care can be continued, and they don't have to go see a specialist, which is costly and also takes time. So we'll talk about resistant hypertension still in 2017. And okay, so here are my disclosures. All of these slides are on the web, and you can follow along. Now, I hope you have your clicker, and I noticed many people are not engaged in taking part in the questions that we're asking, and I am going to ask some questions. Would you rather me do it by a show of hands? Yes. Okay. Is that okay, Dylan? Can we do that? Okay. So what I'm going to ask you to do is not answer until I ask, and then without looking at your neighbor, it's either up or down so that you're not biased. Can you do that? Best you can. So here are the pretest questions. It's always better with the clicker, but we don't have clickers. First question, according to the NHANES data set, the estimated prevalence of resistant hypertension in the United States with the new blood pressure target of less than 130/80 is 1% of all adults, 5% of all adults, about 13% of adults with hypertension treated with antihypertensive agents, about 50% of patients with kidney disease, or about 17% of adults with hypertension treated with antihypertensive agents. So with that, should I just leave it on this? Okay, I'll leave it on this. And how many think it is A, 1% of all adults? B, 5% of all adults? Okay, a couple too. C, about 13% of adults with hypertension, many of you. About 50% of patients with kidney disease? Okay, a couple. And about 17% of, okay, so more of you think E is the correct answer than C, which was the next most correct answer. 17% of adults with hypertension treated with antihypertensive agents, or 13%. Okay. Question 2. And that was that. Approximately what proportion of patients felt to have resistant hypertension by clinic measurement actually have white coat hypertension when using 24-hour ambulatory blood pressure monitoring? A is nearly 0, B is less than 10%, C is about 1/3, D more than half, or E none of the above. So how many of you think of those felt to have resistant hypertension actually have white coat when you do a 24-hour ABPM? A, nearly 0, 1. B, less than 10. Okay, a good number. C, about 1/3. Most common answer. D, more than half, 1 or 2. E, none of the above. Okay, so the most common answer right now is about 1/3, C. Okay. And there are some people answering. In an adherent, truly hypertensive patient, after a RAS blocker, thiazide diuretic, and CCB, the fourth drug class added in those with resistant hypertension should often be A, a beta blocker, B, a mineralocorticoid receptor antagonist, C, an alpha blocker, D, a loop diuretic, or E, none of the above. Okay, 3 drugs, 3 good drugs, still resistant, truly hypertensive. How many think you'd add a beta blocker? Okay, a good number. B, a mineralocorticoid receptor antagonist, even more. C, an alpha blocker. Not many, but some. D, a loop diuretic. Okay, and E, none of the above. 1. Okay, so it looked like B was the most common answer. And then finally, I really wish you could take this. On a scale of 1 to 5, please rate how confident you are in working up and treating a patient with resistant hypertension. Not at all, slightly, moderately confident, pretty much confident, or very confident. Okay? And let me just go to this. Dylan, if you can raise it up a little bit. I'm going to let some of the people, who are answering with their phones or tablets, or just to do this. But by a show of hands, how many of you currently are not at all confident? Are slightly confident? Okay, a couple. Moderately confident? Many more. Pretty much confident? Oh, very good. Or very confident. Okay, so it's bell-shaped, and it's a little bit more moderately confident than pretty much confident. Hopefully that'll change by the end of the talk. Okay, so let's go. Here are the learning objectives. After participating in the activity, you'll be better able to understand the definition of resistant hypertension, review the clinical workup of resistant hypertension, including the importance of out-of-office versus 24-hour ABPM to secure the diagnosis, recognize the importance of lifestyle modification and the evidence for the use of chlorthalidone versus hydrochlorothiazide, and mineralocorticoid receptor antagonists with antagonism with either spironolactone or eplerenone as a fourth drug to improve blood pressure control in those with resistant hypertension. Okay. So here's a case, patient that I saw. Sam's a 58-year-old man with a 20-year history of hypertension who is new to your practice. With a BMI of 32.2, he has no history of ASCVD, diabetes, or other vascular disease. He has been treated with antihypertensive drugs for the past 10 plus years, including a combination diuretic ACE inhibitor, which had to be stopped due to a cough. He states his blood pressure has never been well controlled, and his physicians have always been concerned over this issue. When I saw him, he's on losartan HCTZ 100/25, amlodipine 10. His blood pressure today in our office was 144/94, appropriately taken with an ambulatory oscillometric blood pressure device. 3 readings after 5 minutes of rest in a chair, supported. I was not in the room. My nurse knows how to take blood pressures, and we do average the 3 blood pressures. Some people will throw out the first and average the next 2. His physical examination was unremarkable, including his eye ground exam, which, as I asked most of the patients referred to me, has anyone ever looked in your eye grounds, in your eyes, anybody taking care of your blood pressure, and you'll be amazed at how often nobody is ever looking in the eyes anymore, which to me is a reflection of target organ disease in hypertension, can be. He has normal renal function, a potassium of 4.2, and his EKG reveals a normal sinus rhythm and voltage suggestive of LVH. So we have some early clues from this new guideline, from the recently released 2017 ACC-AHA guideline, but we wait for the new guideline coming out early in this year, coming year. So here's the AHA scientific statement that we last had. And as you can see, it's 2008. It's almost 10 years in the making from the last statement. Resistant hypertension, diagnosis, evaluation, and treatment. And if you look at the JNC7 definition from 2003, resistant hypertension was a blood pressure that remains above 140/90 in patients adhering to an adequate and appropriate triple drug regimen, including a diuretic, with all drugs prescribed at near maximum or maximum recommended doses. Now, the 2008 scientific statement agrees with the JNC7 definition. and they called it uncontrolled blood pressure, despite the use of 3 medications, including a diuretic. But they added another category, and that was controlled resistant hypertension. And that will be in the new document as well. These are patients that are on 4 or more medications, but their blood pressure is at the target. It's less than, in this particular document, less than 140 over less than 90, how we defined hypertension in the past. And what they're trying to tell us there is that when you see someone on multiple medications, even if they're controlled, and I like the fact that they're controlled, you may look at interfering substances, other things going on, high salt diet, lack of lifestyle modification that may enable you to decrease the burden of drug while you can still control their medicines. So it's not necessarily a time to relax on some of the things we can do to drive blood pressure down independent of drug use. But control is control. I like people that are controlled, and sometimes it will take 4 medications. There's another category called refractory hypertension. These are patients uncontrolled on 5 or more medications, and they are very, very challenging. Not that you necessarily approach them differently than you do resistant hypertension, but they are a very challenging group of patients. So here's the new definition from the 2017 ACC-AHA guideline in your handout on the web. It's an office systolic diastolic greater than or equal to 130 over 80, and patients prescribed 3 or more antihypertensive medications at optimal doses, including a diuretic, or office systolic diastolic less than 130 over 80, but the patient requires 4 or more antihypertensive medications. So all they've done is taken the 140 over 90 and substituted for the new target of 130 over 80 to make this their new definition of resistant hypertension. Well, if you look at the old information before the new 2017 ACC-AHA update, the true prevalence of resistant hypertension is not known, but depending on the locale, you can estimate the prevalence. So in our practices, it's about 10 to 30%. And you can go on the EMR and ask them to look at 3 or more antihypertensive medications, including a diuretic, and blood pressure above the target that you're looking at. If you have 1,200, 1,500, 2,000 patients in your panel, you can see by ICD-9 code how many with hypertension are not controlled on those parameters. If you're a specialist, like a nephrologist, you're not going to see garden variety hypertension as often. You're going to see CKD, and these patients are more likely to be resistant. So the number of patients you're going to see with resistant hypertension will be increased. And it really spans from wide varieties, from 20 to 30 to maybe 50 or more % in nephrology clinics. Now, if you look at the National Health and Nutrition Examination Survey, it's about 9% of all of us with hypertension, all adults with hypertension, and it's about 13% of all antihypertensive drug-treated U.S. adults with hypertension. That's in the past. Now, the recent estimates suggest that the prevalence is increasing, and if you go to the new definition from the ACC-AHA 2017 guideline, it's about 17%. So by lowering the threshold from 140 over 90 to less than 130 over 80, you're increasing the prevalence of resistant hypertension, estimated about 4% to 17%. So there are a number of questions I'd like to pose to you. Our patient Sam has resistant hypertension, yes or no? The answer is yes. He's on an appropriate 3-drug antihypertensive regimen, including a diuretic at maximum or near maximum doses, and his blood pressure is greater than 140 over 90, and certainly he would qualify if we were looking at greater than or equal to 130 over 80. You'd be surprised, and I run a resistant hypertension clinic at the medical school now, having been retired from the VA. You'd be surprised at the type of patients referred on clonidine, a beta blocker, and hydralazine. And as I'll talk to you, the first 3 drugs that we should be looking at, and we talked a little bit about this in the guideline yesterday, should be in no particular order, depending on ethnicity and age and comorbidities, but should be an ACE or an ARB, a diuretic, and a CCB. And those are 3 drugs that work tremendously well pathophysiologically together, and they work very well for outcomes, for cardiovascular and cerebrovascular outcomes, heart failure prevention. So I'd like you to think about those three drugs as the first three drugs in most patients you see with hypertension as classes of drugs, unless the patient has a compelling or a specific situation where other drugs should be used. And we'll talk about that in this talk. Now, how important is differentiating pseudo-resistant, or what looks, feels, and smells as if it's resistant hypertension, from true resistant hypertension? And it's very important. In fact, on the right are these with apparent resistant hypertension, and on the bottom left are those with true resistant hypertension. So what can be causing pseudo-resistance or apparent resistant hypertension? They look, feel, and smell as if they're resistant, but something else is going on. Well, it can be the blood pressure measurement that is improperly taken. It can be the white coat effect. Remember we said in the document yesterday, if the blood pressure is 130 to 160 or 80 to 100 in your office, you need to make sure from out-of-office blood pressure or ABPM, if it's available, that the patient does not have white coat hypertension, unless they already have comorbidities, target organ disease, etc. That's representative of hypertension. So the white coat effect can be very important. We'll talk about that. Adherence. Are good patients who mean well don't take their medicines. They may not fill their medicines, and unless you ask the patients to bring their bottles, they may bring you a list, but they're not taking their medicines. And they may bring you a bottle that's a year old. So in my practice, at the VA, I've always had an area on the desk where they line up every medicine they get from every clinician and over-the-counter or alternative medicines. I just want to see what they're on, and I want to see the last filled bottle. And I open up the top, I look in there, I look at the date. I mean, I go through the whole exercise because I want them to know I'm concerned if they're taking their medicine or not. In fact, I want to work with the pharmacist so that instead of just taking the medicine off the shelf and restocking it, I want the office to be called when patients don't come to the pharmacy to pick up their medicine. Because if they don't do that, you'll never know 3 to 6 months later, although now we're recommending every month when you're using drug therapy, or 3 to 6 months when it's lifestyle, you'll never know that the patient hasn't gone to the pharmacy to pick up their medicine. And yes, you can say, okay, it's on them, but it's on all of us. And we've got to work with our patients to look at adherence. And then there are these poor medication regimens. Good clinicians just choosing the wrong medicines to try to control the patient's blood pressure. Okay, so let's first look at improper blood pressure measurement. I don't want to spend too much time on this, but as you know, there are 6 key steps. I went through them in length yesterday. Properly prepare the patient, use the proper technique for measurement, take the proper measurements needed for diagnosis and treatment of elevated blood pressure, hypertension, properly document the accurate readings, average the readings, and provide the readings to the patient. Let them know how well they are or are not controlled, so they have some knowledge of this and communicate that to all the other clinicians that they see. Very important. So we can get rid of measurement because you're all going to do that very, very well. Now, what about the white coat effect? It is a problem, and it's often unrecognized. And a patient in your community may see Dr. Jones. You have respect for Dr. Jones. Dr. Jones now has the patients on 2 medicines. Patient now comes to see you for the first time because his insurance switched, whatever. And he's already on 2 medicines. He's not controlled in your office. He hasn't had any events. You may do lab and they're all good. He doesn't have protein in his urine. I mean, you can look at his eye grounds and they look good. And you add a 3rd medicine. But the reality is we've really got to rule out a white coat effect, because a lot of patients have this, some of which is built on the way we take blood pressure in the office, rushing them into the office, etc. Now, yesterday someone very nicely asked me, but Dr. Basile, this is their real life. They are running all around and all of this. Well, I understand that, but for the most part, if you do a 24-hour ABPM, their blood pressure is not up if they're normotensive, even when they're rushing around. It's sporadically elevated, but the burden of blood pressure is not elevated. And that's the purpose of standardization of blood pressure measurement, So we're all using the same standard, and instead of inappropriately adding medicines, we can try to standardize if they truly have hypertension, a very important point. This is a study of almost 8,300 Spanish hypertensive, every one of which got ABPM. And 1 out of 8, 12.2%, on the far left, had office-resistant hypertension. In the office, their blood pressure was 140/90 or greater, and they were on 3 good medicines, including a diuretic. And when they looked at their 24-hour ABPMs, they found that a third of them had white coat resistant. By 24-hour ABPM, they did not have hypertension. And so it's very important. Home measurements can be helpful. And what is the best way to do home measurements? Pick a week out of the month that they don't see you. Get 2 pressures in the morning and 2 pressures in the evening. And throw out the first day, so you're left with days 2 through 7. This is a good way to look at what their blood pressures are out of the office. You don't want to just do it in the morning. You don't want to just do it after they take their medicine. And let them bring you those values. Or you can do it another way. But in this study, 1/3 of patients felt to have apparent resistant hypertension. Was not true resistant. It was secondary to a white coat effect. Okay. Medication adherence. We've got good patients. We love them, but they don't always take their medication. Now, certainly, if they're on a beta blocker and their heart rate is not reduced, that can be helpful. But for the most part, it's very difficult to know if patients are taking their medication or not. And it's a huge issue. It's a huge issue. So, adherence. This is a study, a German study, in which they use fluorometric evaluation of the urine, something not quite yet available to us in practice, in patients that were referred for uncontrolled hypertension on 3 medications. And they wanted to know why these patients weren't controlled. So when they maximized their doses and excluded white coat, they got rid of apparent resistant hypertension, and that got rid of almost 2/3 of the patients, right? They left with 108 uncontrolled. Then, as we will go through the exercise, they ruled out secondary causes, and they added a 4th drug, and then they were left with about 1/4 of the patients still uncontrolled. Now, why are they uncontrolled? When they looked at their adherence to medication, they found that more than half were not taking their medications as they should have by urinary fluorometric analysis. 30% were not taking any of the medications, but 70% were taking what they felt was best. And of that 70%, 85% were taking less than half of the medication that you prescribed for them. How do we reconcile this? We reconcile this with honesty, encouragement, spouses and family members that can be involved if that's an issue of taking their medicine, and just conveying to them, if there's ever a day you can't or don't take your medication, please let me know. Because if not, I'm going to add more medication, and you're going to end up feeling awful because I think you're not controlled. You're taking more medicine, or maybe you're not taking any of it, and I'm just confused. And you and I are a team. We work together to control your pressure so you don't have a stroke, a heart attack, ever develop heart failure, which we'll talk about after the break. Don't develop kidney disease, and don't develop peripheral vascular or death, peripheral vascular disease or death. So hypertension is clearly, the most important risk factor for cardiovascular morbidity and mortality, and the second most important controllable or modifiable risk factor for death, overall mortality after smoking. So please understand that apparent resistant hypertension is an issue, and adherence is something somehow we've got to wrestle with. And I personally believe there should be a sign. I'd love to see it in all offices. You can tell me I'm wrong, but when you come for your appointment, please bring all your last medication bottles to your visit. I just think it's important. And I think it's important for us to look at those bottles. It shouldn't take very long, but we're just conveying to them the importance of adherence in controlling their pressure. Now, this is an even more important study, in my opinion. This is the Diener hypertension trial. This was a resistant hypertension study at elite hypertension centers in France, where they were double-blindly randomizing patients, as we'll talk about a little bit later in the talk, to renal denervation with radiofrequency ablation of the sympathetic nerves that travel outside of the renal artery in an effort to control blood pressure over optimal medical therapy versus optimal medical therapy alone. Double-blind randomized trial, Diener hypertension. All the doctors in the trial that were investigators were hypertension specialists, not just cath jockeys, hypertension specialists seeing the patients. Patients instructed repeatedly to take the medication. Someone did the procedure, but the patients were followed by a hypertension specialist. Reminder messages were sent to the patient's home by either phone or cell or telephone or text. Adherence was tested with blood and urine tests, and all patients knew in their protocol, in their informed consent, that they would be tested for adherence. When you look at the results of adherence, you see that 50% of the patients, both in the renal denervation group and in the control group, were non-adherent. Some were just flatly, totally non-adherent, but most were partially adherent. These are patients that are volunteering for a study in an effort to be able to show that renal denervation and medical therapy is better than just medical therapy. They know they're going to be tested if they're taking their medicines, and they're not taking their medicines. Rigorous commitment to patient drug adherence involving frequent doctor visit and nurse reminders, messages to patients' homes and families, and the aggressive use of adherence testing with plasma and urine samples appears to be beneficial. These strategies can improve patient drug adherence. This is from the article, from the paper, 2016, from bad to mediocre. But even in the best of hands, adherence remains a largely unresolved problem. I don't have the full answer to this, but I know that with concern and commitment and care, patients will be better off than if there isn't that. But I don't know the best way, and maybe in the question and answer you can help me with that. And then finally, a poor medication regimen. All causes of apparent resistant hypertension. Looks, feels, smells like it's resistant, but it's not really resistant. And I just want to go over medication regimens. This is what I think is going to be in the 2018 guideline. It's not as evidence-based as I would like, but I think the standard triple therapy will be a RAS blocker, a CCB, and a thiazide in optimal doses. You can consider a single pill combination. It can be a little costly, or you can use a combination with a third drug, whatever works best for you. In our renal denervation studies now, we are comparing the trio group, and there are 2 trios available in the world, but they are not generic and they're not as well priced as some of the single or combination drugs that you all are familiar with. Then, as needed, I'll show you the reasons why we are committed to mineralocorticoid antagonists as the next drugs, either spironolactone or eplerenone. You can use an alpha blocker, a beta blocker, or an alpha beta blocker. Other agents and loop diuretics. I like amiloride. It is potassium sparing at 1 milligram to up to 10 milligrams, or 2.5 to 10 is the usual dose. Be aware, if you're using it with an ACE and a mineralocorticoid, you need to watch the K and renal function very carefully. Lasix lasts 6 hours. If you're using it for blood pressure reduction, it is not an antihypertensive, but it lowers blood pressure. Remember, these are antihypertensives, these other drugs. They work on the vasculature, and they work on potassium blockade like a thiazide to lower peripheral vascular resistance. These other drugs will get rid of volume. And direct vasodilator, so the old day of hydralazine, minoxidil, hydralazine, and a beta blocker, not really in vogue too much now. No real need for it. Remember, the ACEs and the ARBs came along, the CCBs in the 80s and 90s. These really added a lot to our armamentarium, so we didn't really have to use minoxidil and hydralazine, beta blocker, loop diuretic as often as we did in the past. Okay, so what do you get when you use those 3 drugs in combination from any 2? Well, here is amlodipine and hydrochlorothiazide. Here is an ARB and hydrochlorothiazide. Here is an ARB and a CCB. Notice, as a surprise to some of you, in a double-blind randomized trial with a mean baseline blood pressure of about 160, 168, 169 millimeters of mercury, there is really not much difference between RAS CCB, RAS diuretic CCB. I know many of you do not use a CCB and a diuretic as your first two drugs. Perhaps in some African American individuals it can be very helpful, but most of us would use a diuretic and a RAS, or a CCB and a RAS, before we'd use a diuretic and a CCB together. But when you add the third drug, you get quite a nice additional blood pressure reduction. And that's the reason why we recommend these three drugs. They work very well together. They really can reduce blood pressure very nicely together, pathophysiologically, in patients with resistant hypertension. Now, which thiazide? Well, I don't know if I mentioned it to you yesterday, but in the ACC 2017 update, a lot of information in there, they actually recommend chlorthalidone as the preferred thiazide diuretic because of duration of action, true 24 hours, not 12 to 14 like HCTZ, and because of the evidence base in the SHEP, the ALL-HAT, and other trials for hard endpoint reductions compared to either placebo in SHEP or other comparators. And so I don't know how much chlorthalidone you're going to use, but I'm going to show you, at least in resistant hypertension, I'd like you to really consider switching from HCTZ to chlorthalidone. Okay, why is that? Well, in this study of patients with resistant hypertension who were uncontrolled on the left-hand side of the slide, and then there is a reference on this, by the way. It doesn't show up here, but it's in your, on your slide package, 2005 Journal of Clinical Hypertension. They just took the same dose of hydrochlorothiazide on the far left, 152 mean, and they changed it to the same dose of chlorthalidone. And look at how much better. It was significant how much better blood pressure was reduced. But better than that is this industry-sponsored trial by the makers of azilsartan. But what they did here to show the benefit of chlorthalidone over hydrochlorothiazide is they double-blindly randomized folks over 6 weeks and 10 weeks to either the ceiling dose of azilsartan as a combination, 40 milligrams, and just for the sake of trade name, that's a Darby. And then they added either chlorthalidone or hydrochlorothiazide, and then they up-titrated, just like you would do in practice, to the higher dose of either chlorthalidone or hydrochlorothiazide. They used the same ARB as the background, and either hydrochlorothiazide or chlorthalidone. And here's what they showed. And look at the differences in the systolic blood pressure. Double-blind, randomized, controlled trial, but look at the differences in these systolics at 6 and 10 weeks. This is chlorthalidone, 24 hours in duration. And for the same milligram dose, it is a more effective blood pressure lowering agent than hydrochlorothiazide. When you use it with a RAS blocker, be it an ACE inhibitor or an ARB, you're going to ameliorate or lessen the hypokalemia that occurred in the SHEP trial. We didn't have ACEs or ARBs in SHEP in 1991, published in JAMA. So yes, we saw about a 20% less than 3.5 K, and we saw a 7% less than 3 K. But we didn't have ACEs and ARBs. And in the product insert for these drugs now, it says that the RAS blocker will lessen the proclivity to develop hypokalemia. Hypokalemia is not good. In general, I would like your potassiums and your hypertensives to be 4 or greater, because observationally, in SHEP, if the K was 4 or greater, they did better than if it was less than 4. Okay? Now, we don't want it to be high because we're concerned about hyperkalemia, but hypokalemia, and I'm talking about 3.5 to 4, that's okay. It's not going to be dangerous, but I think they do better if they're around 4. Okay. So chlorthalidone over hydrochlorothiazide. Maybe not for everyone, but certainly in resistant hypertension, this is a different group. Now, how important is it to differentiate pseudo-resistant or apparent resistant hypertension from true resistant hypertension? Very important. Because these people account for about 50% of the patients who appear to be resistant and they're not really resistant. Okay. Let's go on to true resistant hypertension. We've ruled out pseudo-resistant. Now, this is from the new guideline. The reference is there. Can't see it on the slide, but it's in your handout, the 2017 ACC-AHA guideline. When should you consider screening for a secondary cause of hypertension? If the patient has resistant hypertension, drug-resistant, or drug-induced hypertension. Now, that is the interfering substances, and I'll talk about that in a second. The abrupt onset of hypertension. You know, there's a bimodal incidence of hypertension, usually between 15 to 18 and 30 years of age, and at an older age, 50 to 70. So that's not unusual. But when someone at age 40 all of a sudden never had hypertension, and now they've developed hypertension, you got to think outside the box. Could there be something else going on? That's what they're saying there. Abrupt onset of hypertension less than 30. This usually creeps up on them, but abrupt onset of hypertension. So I've seen people refer to me with fibromuscular disease. Often women more than men, can be black, can be white, doesn't matter. We used to think it didn't occur in African Americans. It does. And they could have fibromuscular disease. So things to think about outside the box. Exacerbation, they were well controlled, and all of a sudden, they're still taking their medicines, but now they're not controlled. Got to think about non-adherence as well. Disproportionate target organ disease for the degree of hypertension. Malignant hypertension, papilledema, got to look in the eye ground, but anybody with malignant hypertension, got to think outside the box. Onset of diastolic hypertension in older adults, because usually diastolic hypertension occurs in younger people, children more than adults, but it can occur in both, combined systolic, diastolic. But systolic-only hypertension is usually an older person's disease, with hardening of the arteries, difficulty pumping out against a forced resistance, and so the systolic, the top number, goes up. When you see isolated diastolic hypertension in older adults, you have to think outside the box. Or unprovoked hypokalemia. Remember, primary hyperaldo is usually seen in normokalemia, but we always think about it when they're hypokalemic. Only about 30% of primary hyperaldo have hypokalemia. When you think about that, and they're outside the box, you're going to screen them for a secondary cause. We'll talk about that in a second. Otherwise, screening is not indicated, okay? And then they do go on to say at the bottom here, if you're uncomfortable with working with them on why they're still resistant or could have a secondary cause, refer them to someone like a hypertension specialist, a cardiologist, whoever you feel comfortable referring them to. In terms of the class and level of evidence, it's a class 1 recommendation, expert opinion. Screening for specific forms of secondary hypertension is recommended when the clinical indications and physical exam findings are present or in adults with resistant hypertension. And then it's a 2B, might be beneficial, might not, certainly won't harm, but if an adult with sustained hypertension screens positive for a secondary hypertension, referral to a physician with expertise in that form of hypertension may be reasonable for diagnostic confirmation and treatment. So if their seated aldo-renin ratio is greater than 20 to 30 to 1, and their aldo is greater than 12 to 15, not just an aldo of 7 and a renin of 0.1, which is a ratio of 70, because they're on an ACE or an ARB and a beta blocker, which can affect the renin and suppress it, etc. But when you think you might be dealing with a secondary form of hypertension, you might want to refer them for a more diagnostic test, okay? Saline loading, whatever the test for hyperaldo is in the community felt to be best at the time, okay? If you're concerned about a secondary cause, there are only certain things to think about. And this is from the new guideline, the 2017 guideline, and all hypertensives considered for secondary hypertension should have a TSH, plus or minus a free T4, all in your handout. For a FEO, our community is divided on what test is best. I like a plasma metanephrine, norepinephrine. Others like a 24-hour urine. Either one is acceptable. For primary aldo, you're going to see it either with a hypo or normal potassium. You're going to get a plasma aldo and a plasma renin, seated, preferably in the morning. and you're going to look for an elevated ratio where the aldo is elevated and the renin is reduced, but the aldo itself should be usually above 12 to 15. Okay? Cushing's disease, hyperparathyroidism, renal artery stenosis, and sleep apnea. I'm going to say some strong things about sleep apnea on this talk. A little bit maybe different than what Roger said, but I am committed to trying to diagnose sleep apnea for all of the things that it's associated with in addition to hypertension. Okay. Renal vascular hypertension associated with renal artery stenosis. This is the CORAL study. It is the last definitive study published in 2014. It is a double-blind randomized trial in patients with atherosclerotic renal artery stenosis. Double-blindly randomized to medical therapy alone versus intervention with stent plus best medical therapy. And in this trial, there was no ability to show any benefit of stent and medical therapy over medical therapy alone. And so how much you should pursue with an MRA or a Doppler ultrasound, depending what the radiologists in your community are best at doing to find this diagnosis, comes down to this recommendation from the 2017 new guideline. Class 1, level of evidence A. Medical therapy is recommended for adults with atherosclerotic renal artery stenosis. So even if they have renal artery stenosis, you're going to still treat them with good medical therapy and get their pressure controlled. But in adults with renal artery stenosis, for whom medical management has failed, these are people who continue to have refractory hypertension on the best medical therapy you can use, worsening renal function in front of you, independent of blood pressure, and you can't explain it, or they come into the emergency room with flash pulmonary edema and or intractable heart failure. And those with non-atherosclerotic disease, including fibromuscular disease, it may be reasonable to refer the patient for consideration of revascularization, either with stent or just angioplasty. Fibromuscular disease, angioplasty, atherosclerotic disease, usually stent placement. So that's the latest update. And this is why many of you, in patients with resistant hypertension, will not be fast to try to do a radiologic procedure. First, try the medical therapy. Watch their renal function. Take the history for heart failure, etc., and follow them. That's the latest we know on renal vascular hypertension associated with renal artery stenosis. Let's move on. Drug-induced or interfering substances. Here's the latest list, and it's from the 2017 updated guideline. There aren't many changes, and I've shown you in this, and you see the reference, the 2008 guideline, the Calhoun guideline, and the new updated guideline in the overall guideline on hypertension. These are drugs that can interfere with blood pressure control. NSAIDs, in general, chronic NSAID use elevates blood pressure systolic 5 millimeters of mercury. However, there are many patients that have exaggerated effects from prostaglandin inhibition, salt and water retention, and vasoconstriction associated with NSAIDs. If at all you can minimize the use of NSAIDs in patients that you're following, I think it's very good. I've used something called trilosate, choline magnesium trisalicylate. It's a non-acetylated aspirin. It's good for pain. I know you have other things you can use, non-opioids for pain, but if you can get them off these NSAIDs, at least chronically, I think it's a good thing. Hard to do in a rheumatoid arthritic or psoriatic arthritic, but we don't want our hypertensives uncontrolled, COX-1 or COX-2, over abusing NSAIDs. Sodium-containing antacids, that's new. Oral contraceptives, estrogen-predominant, high dose. Sympathomimetic agents, stimulants, alcohol, antidepressants. Some of the TCAs and the SNRIs can do that. Venlafaxine at higher dose, certainly at 225. That can elevate blood pressure. Be aware of that. Cyclosporin and tacrolimus, erythropoietin, licorice, natural licorice, not deglyceride licorice, and herbal compounds. So you got to know what the patient's taking. Interfering substances. What about sodium and volume overload? There are patients in our practices that have no edema and have too much intravascular volume for the degree of blood pressure. and have an abnormal sodium volume relationship through their kidney. And in this study, small as it is, from the University of Alabama, they took 12 patients who were on a mean of 3.4 blood pressure medicines with resistant hypertension. And they were on a 3 to 6 gram salt diet on average. And they double-blindly randomized them to an unpalatable 50 millimole per day sodium diet or a 5.75 gram sodium diet. Remember what I told you yesterday about sodium? They want less than 1,500 milligrams per day of sodium, but they want you to reduce it at least 1,000 milligrams from what their baseline is. And in this double-blind crossover trial, where patients served as their own control with a 2-week washout from that 50 millimole per day, 1 gram sodium diet to a 5 gram plus sodium diet. Look at this. The difference from a high to a low sodium diet, 20 millimeters, small study, 12 patients serving as their own controls in systolic and 9 in diastolic. If there's a way you can get a dietitian involved or do a spot urine sodium or look at their cultural or their sodium use, processed foods, frozen foods, it can be very helpful. Reducing sodium in the diet, especially in resistant hypertension, can be very, very helpful. And certainly chlorthalidone has a role there as well. If you're going to use chlorthalidone, it's 12.5 to 25. In some elderly patients, I will use 6.25, but it's not scored, so that's a challenge. Metabolic complications are slightly worse, hypokalemia, but greatly attenuated when used with a RAS blocker. May be given with Spiro, but watch out for hyponatremia, because there's the perfect storm. Elderly patient on a low sodium diet, taking in free water through the fountain or the bottle, on an SSRI that can cause a pseudo-SIDH, and you've got them on a potent thiazide and spironolactone. And they call you, mom is just not acting right. She's confused, she's not knowing where she is in the nursing home. Be careful, because you can get into problems, not only with potassium, but with sodium and hyponatremia. So that's a little warning there. But I use a lot of spironolactone and chlorthalidone and don't get into too much trouble. In the diuretic uses, I like the loops when there is edema and visible volume excess. When the creatinine clearance, the estimated GFR is less than 35, be careful. We're not sure if hydrochlorothiazide functions there. Chlorthalidone less than 30. Got to go to a loop diuretic, estimated GFR. And that's all in here. Lasix lasts 6 hours. If you're going to use Lasix once a day, that's the devil's doing in hypertension, Lasix once a day, because you're going to get paradoxical sodium reclamation, okay, in the distal tubule collecting duct. So you're going to end up worse than when you started. Lasix is a 2 to 3 time a day drug. You can use a long-acting, generic, well-priced loop diuretic if necessary. Remember, I like antihypertensives and I use loop diuretics when I have to. Visible volume excess and renal insufficiency. Just to show you, spironolactone has a very long half-life. When I trained, we used to give spironolactone for portal hypertension and cirrhosis 3 times a day. It's a once-a-day drug. Very long half-life. Amlodipine, once-a-day drug, very long half-life. Chlorthalidone, once-a-day drug, very long half-life. Enalapril, the only BID ACE inhibitor, good drug, BID, and atenolol. I think it's best to give it BID. Hydrochlorothiazide in the Kaiser system is given 20-25, lisinopril hydrochlorothiazide BID. 20-25 BID. So that way you can get 40 and 50. Remember, in the hydrochlorothiazide studies, VA1 and 2, we used 50 to 100 of hydrochlorothiazide, and the outcomes were good. But we have never been able to show that at 12.5 to 25, even though it lowers blood pressure. And blood pressure reduction is what we measure our success on. Okay. Hyperaldo or idiopathic hyperaldo, non-Conn syndrome, non-tumor associated reactive hyperaldosteronism is common in resistant hypertension. And in this open label trial, when spironolactone at 25 to 50 was added over placebo as a 4th drug, the first 3 being a RAS diuretic CCB, look at the difference in blood pressure with only 6% discontinuation. due to adverse events. So we like the mineralocorticoid receptor antagonist as a fourth drug. Got to watch the K, got to watch the renal function. And in this more recent trial that you can't see the reference, but this is by Brian Williams out of London in 2015. This was a 285 patient, 230 completed all cycles, serving as their own control, with resistant hypertension, who were double-blindly randomized to either spironolactone, then doxazosin or bisoprolol or placebo. And the bottom line was, among patients with resistant hypertension, spironolactone was the most effective add-on agent for improved blood pressure control. Spiro improved systolic pressure nearly 9 millimeters versus placebo and about 4 millimeters more than the comparators. So bisoprolol is a European beta blocker, very good in heart failure, has good outcomes there after the break, and the alpha blocker, doxazosin. I like all these drugs, but spironolactone, I think, is a hero drug. It's a hero drug. I think it makes clinicians heroes with their patients. Okay. So, Spiro, 12.5 to 25. You may need to go higher as necessary. Hyperkalemia is uncommon. And it's the 45, 4.5 drug. If the GFR is less than 45 or the K is greater than 4.5 at baseline, be careful. Certainly if the GFR is less than 30, I wouldn't use it. Or if the K is greater than 5 to 5.5, I'd be very, very less likely to use it. We do now have potassium binders. That's another topic. But I don't see much gynecomastia with these drugs. Certainly eplerenone less than spironolactone because it doesn't have the androgenic and estrogenic effects, but it's priced a little more. It's a little more pricey than Spiro. And why we saw the breast tenderness, in my opinion, was because in heart failure, when we used Spiro in the day, we used it with digoxin. And we don't use a lot of digoxin today in heart failure. So I don't think we see as much breast tenderness and gynecomastia. Certainly in the VA, and I've been there since '78. I saw it back in the day, but nah, we use a lot of Spiro. I don't see a lot of gynecomastia. So this just goes through everything. Chlorthalidone should be preferred and resistant. Mineralocorticoid receptor antagonism. Eplerenone, a little more pricey. It starts at 50. You can go to 50 BID, 100 BID, 200 BID. Use it BID when you use more than 50 a day, and consider amiloride. Potassium sparing, but a very nice epithelial sodium channel blocker can be a hero drug as maybe a fifth drug or a sixth drug, watching the K and the renal function carefully. Okay. We're trying to move. Okay. Associated conditions, alcohol intake, obesity, and sleep apnea. These can all contribute to resistant hypertension. CPAP reduces blood pressure, but does not cure hypertension. Okay. So, patients in your office, certainly he's sleeping, he's got sleep apnea. Obstructive sleep apnea and cardiovascular disease, about 35% prevalence in those with overall hypertension. In drug-resistant hypertension, 65 to 80% prevalence. It's probably the most common secondary cause of hypertension. Coronary artery disease, 30% prevalence, heart failure, atrial fib, stroke. It's out there. It should be recognized. The problem is, in a double-blind randomized trial for blood pressure, it minimized blood pressure reduction by 3/3. 3 systolic, 3 diastolic in a double-blind randomized trial. And the primary endpoint was the change in 24-hour ABPM. So, not much different in blood pressure reduction. Why do I have trouble with this? Okay. But it's important for the concomitant conditions linked with sleep apnea, because sleep apnea is associated with increased stroke, MI, heart failure, atrial fib, and chronic kidney disease. So I'm all for CPAP, but I don't think it's going to make all that much difference in blood pressure reduction. In addition, and I know Roger told you, Dr. Schwelt, a lot of good things, tremendous, about sleep apnea yesterday, and I agree with them. But in this New England Journal article from 2016, which is often quoted in patients with underlying coronary and cerebral vascular disease, high risk, from Australia, over 2,700 of them. When they double-blindly randomize them to CPAP versus non-CPAP, and all other therapies being kept very good, they were not able to show any benefit in the composite primary endpoint of cardiovascular and cerebral vascular events. So yes, CPAP's important. Yes, it will help lower blood pressure. It's not going to make all that much difference in blood pressure, but we need to do it. But we still don't have evidence that it really is an evidence-based strategy for hard endpoint improvement. Here's what we say in the 2017 guideline on sleep apnea. In adults with hypertension and obstructive sleep apnea, the effectiveness of CPAP to reduce blood pressure is not well established. Okay. Clinical inertia. This is on us. Adherence may be on our patients. Clinical inertia is on us. This is the failure of the healthcare provider to initiate or intensify therapy when indicated. And this is from a study that we did in Charleston. Brent Egan's the lead author. And if you just look at why people are uncontrolled in the National Health Nutrition Examination Survey, 52% are untreated, okay. And 34% have clinical inertia. They're uncontrolled and they're taking less than 3 medications. And for some reason, the patient bargains with the clinician or the clinician just doesn't add another medication. And they're suffering from clinical inertia. Okay, oh, we got it. So this is a study that we did in Charleston as part of our hypertension initiative. And we looked at a large number of practices in North Carolina, South Carolina, and Georgia. 7,200 plus patients. They had 4 visits in a year or more, and one of them had elevated blood pressure through their EMR. And we looked at those clinicians that suffered from therapeutic inertia in red versus those that didn't. They would either up-titrate or add a medication. And the bottom line is, if you don't suffer from clinical inertia, you're more likely to get blood pressure controlled. Okay, you're more likely to get blood pressure controlled, and these are the blood pressure differences. So don't suffer from clinical inertia. Okay, those are the causes of true resistant hypertension. Device therapy. None of them are FDA approved. Either carotid baroreceptor therapy, okay, BAT therapy, baroreflex activation therapy, or renal denervation. But we do have a recent trial that got us back on the map with renal denervation. By radiofrequency ablation or ultrasound thermal energy, this study in which patients were either on 0, 1, or 2 medicines and then got an ABPM off their medicines and double-blindly were randomized to either renal denervation or no renal denervation. For the first time, double-blind randomized sham-controlled trial, spiral hypertension, and the reference is on here, just not shown on the slide. It's on the bottom of the slide. There was a significant reduction in 24-hour ABPM and in office blood pressure. So we're back on the map. We're continuing with a number of renal denervation trials. Stay put. It looks clearly safe when you look at renal denervation from sham control. Patients are put into the cath lab and they are wearing a headset and they don't know if they get the active procedure or the sham control. And there are no side effects. So it's safe. We have to see if it's effective. Currently not ready for prime time. And this is most important. I wanted to share it with you. This is the scatter plot. And the problem is that there are patients that do not respond in red and patients in green that do respond, okay? And so we have to learn the phenotype of patient that's most going to respond to renal denervation. Finally, bedtime dosing of antihypertensives. So when they're resistant, they're on 3 or more classes of medications. You might consider giving the RAS blocker and a CCB at bedtime. Because in this study, with 24-hour ABPM, if one of the drugs were given at bedtime in orange versus all 3 given in the morning on awakening, they were less likely to be controlled if all of them were given in the morning. So this may help with blood pressure control. So in the future, we may define resistant hypertension as an elevated blood pressure in patients fully adherent to maximally tolerated doses of multiple drug regimens, including a long-acting thiazide diuretic, chlorthalidone preferred, and a mineralocorticoid receptor antagonist like spironolactone, while on a low-salt diet. In addition, as part of their workup, patients should have, in my opinion, a 24-hour ABPM. We'll see what they say in the new guideline about out-of-office measurement versus 24-hour ABPM in this situation. On the morning after personally administering their medications. So you know that now they're taking them. Then you put on the 24-hour ABPM so you can see what their pressure is on what you think they're taking, and not white coat resistant. Rule it out. Emphasizing once-a-day medications when possible should improve adherence, even if one or more antihypertensives is taken at bedtime when they get in bed with a glass of water. It's an important statement, I think, that I'm trying to make, and it has a lot of caveats in it. So Sam came to us, 58, 20-year history of hypertension on losartan, HCTZ, amlodipine. He's resistant. Our plan, we changed losartan HCTZ to a more effective ARB and chlorthalidone. I added Spiro. I watched his K creatinine and sodium. I saw him. His blood pressure fell to 128/82 over 3 months. I was on the phone with him in communication, how he was doing. I got some bloods on him out of the office and got the lab. I could look it up and make sure that he was doing fine as I was adding the Spiro. And he did very well. Very well for drugs. So resistant hypertension is a medical problem that's increasing in prevalence and of clinical concern. The mechanisms are multiple, but aldosterone excess and high dietary salt ingestion contributing to persistent intravascular fluid retention without clinical edema appears to be an important contributing factor. Treatment is predicated upon lifestyle changes, combining agents from different classes at effective doses, with effective use of diuretics, including mineralocorticoid receptor antagonists, such as Spiro and, when necessary, eplerenone. Future approval of device therapy in the U.S. to treat resistant and stage 1 and 2 hypertension, which is being evaluated, remains uncertain, but is being studied further with both ultrasound and radiofrequency ablation devices. So, with that, good? We're going now. Questions. So I had those post-test questions, and Dylan, I don't know why. What is my problem? Let me see if I get up here, if it's any better. Okay, so by a show of hands, how many think that the new prevalence of resistant hypertension at the new target is 1% of all adults, 5% of all adults, 13% of adults with hypertension? Okay, so that's the old answer. 50% with kidney disease, 17% of hypertension, and that's the best answer. It's E, and that's good. That's the old answer. Don't even have to answer. Let's move on. Next slide. Okay, and that's the correct answer. Approximately what proportion of patients with resistant hypertension by clinic measurement are actually shown to have white coat when using 24-hour ambulatory blood pressure measurement? Nearly 0, less than 10, about 1/3. That's the correct answer. More than half, none of the above. Okay, and it's about 1/3. And the next. In an adherent, truly hypertensive patient after a RAS blocker, thiazide diuretic, and CCB, the fourth drug class added in those with resistant hypertension should often be a beta blocker. Okay, people will do that. A mineralocorticoid receptor antagonist, yes. An alpha blocker, a loop diuretic, or none of the above. And all of them could be used, but if there's no compelling reason to use something other, I like Spiro in that situation. Okay, and then finally, just tell me on a scale of 1 to 5, how many of you now feel not at all confident in treating resistant hypertension? Slightly confident? Still no hands. Moderately confident? A couple. Pretty much confident? Or very confident? Wow. Okay, so we shifted it. That's awesome. I'm happy with that. From like a 3 to more of a 4 and a 5. And I hope that's true in your practice. So with that, thanks. Let's have some questions right over there. Thank you.
I'm concerned about blood pressure measurements as recorded in the chart being used as a quality measure affecting reimbursement. We have a large clinic in New Orleans, and the physicians who work for that clinic were instructed if the patient has a blood pressure over, quote, target, to ask them what their home blood pressure was. And if they get 150 over 90 in the office, but they say, oh, at home it's 120 over 80, record the 120 over 80 as the blood pressure for that office visit. Is this something that's going on all over the country, or is this one of those uniquely New Orleans things?
It's ubiquely, particularly in New Orleans. Let me tell you, our government, our healthcare government, believes that the last blood pressure of measurement is in a clinician's office. And they have always believed that. And they will not accept currently home blood pressure measurements as the last measurement of record. And that has been a problem. And we are fighting with them about this. But no, you cannot use an office measurement as an acceptable blood pressure measurement, but you can use it in your decision making on the chart as to why you might not treat them with blood pressure medication because you think they have white coat. I personally think an ABPM in the white coat situation is best. It's documented. It's an ambulatory Holter monitor of blood pressure, and I think that's the way to go. And most Medicare and insurance companies will reimburse for white coat hypertension. Yes?
Yeah, I have a question. How do you interpret the 24-hour
blood pressure monitor determining cutoff for uncontrolled hypertension versus non-hypertension?
Well, the thresholds are now changed. And at nighttime, it is less than 110 over 60. During the day, it's 130 over 80. And overall, it's 130 over 80.
Do you have a percentage of time that they're in those blood pressures that helped you determine the correct
Their threshold in the past cannot be, they have to have at least 40 readings, and their threshold has to be below good readings at least 40% of the time. I mean, but it depends. So you look for dipping, you look for their daytime blood pressure, and you look at the pattern of their blood pressure. Yeah. And that's in the new guideline, by the way. Yes?
How are you? I have a young patient. He came to me at 18. Just isolated systolic levels that are high. 140 or whatever, healthy. The only history is he was on Accutane. And we watched him for a couple of years. He had a full secondary workup, was negative. And he started creeping up like 149, 150. We treated him. But is it typical to just have isolated systolic in that age group? And I've read a couple of things about spurious systolic in athletes.
Yeah, it's not common, but it happens. And diastolic alone hypertension is a little more common in the adolescent and the young adult than isolated systolic hypertension in the adult. I would look at exogenous substances and anything like that, and I think you were right in following them with lifestyle, etc. And then get their family history, look at other things, and if they need treatment, you would consider that. Once again, his blood pressure is 130 to 160, and so you would consider a white coat effect. And maybe, certainly, home measurements are essential there, and or an ABPM.
What would you start him if he did start creeping? Do you have a drug of choice in the young with just isolated systolic?
I don't have a particular evidence-based drug, but I would like a CCB, I think, would be a great drug, like an amlodipine 2.5 or 5 to start. I think that would be great. If he's an athlete, depending on his heart rate, some people might consider a beta blocker. Certainly, I'd look at the EKG very carefully for LVH, but I don't think you can justify an echo in that particular individual.
Can't justify?
No, I don't think for cost. If you could get a hypertensive echo, maybe, because the echo is much more sensitive than the EKG for LVH. But if you see LVH on an EKG, it'll be on the echo. Yes?
I have a subset of patients with hyponatremia that are already having different drugs. What's the next drug that you would use, not using a diuretic, on your experience, more effective?
Well, if you can't use a diuretic, you got to think of the other drugs. So you could use an alpha beta blocker. You could use, you know, all the other drugs that are out there.
Labetalol, clonidine.
Labetalol, carvedilol. I like carvedilol a lot. I like carvedilol a lot. Those are some of the things you have to think about. But I look at the sodium very carefully and what's going on. You know, why are they hyponatremic? Are they hyponatremic in the setting of excess sodium in the urine, where you're looking at, are they euvolemic? Are they orthostatic? Just a number of things. Do they have edema? Just the general workup for hyponatremia.
Thank you.
Yeah.
Right behind you.
Okay.
Hi, good morning.
Yes.
Thanks for that. I've had several patients with truly resistant hypertension who've seen the cardiologist. They actually were started on magnesium, which worked amazingly. And the reason why I bring this up is because maybe it would increase patients' adherence to a, quote, medication if it's a supplement. How often do you see that used? When should we implement it if you do see it used?
I haven't seen that much.
Oh, you haven't?
No.
I've seen it quite a bit in our practices.
Hypomagnesemia can occur with diuretics, but I haven't seen it all that much.
Okay.
So
you'd
you're
probably have to
telling me
take
that
off
their
some
plasma magnesium is reduced as well?
It may be, yeah. I didn't know if there was, you know, should we advise this for many patients, even at a low dose? That might be another
Well, magnesium
question.
oxide, 200 TID, I don't think that's a problem, but I think
Right.
you have to be careful in using it
Sure.
chronically.
Sure.
I don't know much about that, actually.
Okay,
Yeah.
thank you.
One more, and then we're breaking.
Any comments on central blood pressure check-in?
Central versus peripheral blood pressure, no, not really. The only thing I'll say is that the aortic pressure is closer to the brain and the heart, and we would like our therapies to reduce central as well as peripheral blood pressure that we use as our measurement. I will say that many classes of drugs, including CCBs, ACEs, and ARBs, seem to reduce central blood pressure as well as peripheral blood pressure. The beta blockers don't seem to do it quite as well, especially atenolol. Does not reduce central pressure as well as peripheral pressure.